Thank you very much, Dr. Charlotte, for that nice introduction. And honestly, you couldn't have a better lecture person representing than Dr. Charlotte for this particular topic, because one of the great things that Dr. Charlotte has brought to the field is this legitimacy and seriousness and scientific rigor that is really important in the sexual medicine space. So very pleased to be able to give this presentation. And also, again, just wanted to reiterate as well on our last speaker, that was eye-opening. I mean, it was an absolutely wonderful, wonderful talk. So thank you very much for that lecture. Okay, by way of disclosure, none relevant for this particular talk. We purposely excluded mechanical devices like vacuum traction for this statement. So by way of background, when you look at penile cosmesis, it's a real broad range of therapies. So we tried to grasp as many as we could and compile them, but it really could be a broad topic in general. Historically, none of these have been recommended because of an absence of data, but as the data started to accumulate, we thought it was time for a position statement. Now, cosmesis is very different than the majority of other therapies out there that we deal with. So, for example, whenever you're weighing this risk-to-benefit ratio, you always have to look at the disease severity. If you have cancer, you have something real severe, you're going to have a higher allowable limit of the types of risks that would be permitted with this type of a therapy. So let's take penile prosthesis, for example. So the patient starts with permanent erectile dysfunction and organ dysfunction. So regardless of whether it's an infection, dissatisfaction, pain, malfunction, what's the worst that's going to happen? You're going to remove the device. What are they going to end up with? Erectile dysfunction. Well, they already have erectile dysfunction. So you're going to allow a higher rate of complications in a case like this. But now if we flip over to cosmetic procedures, it's quite a different analysis here. You have a healthy patient population, which is automatically going to raise that bar a little bit. Plus, you've got a higher rate of psychological factors, and you've got someone who's going to live a very long time. This isn't a 75-year-old you're putting a prosthesis in. This is a 20-year-old who's going to have 60-plus years of usable sexual life. Also, the regulatory approval process played into our considerations for this. When you look at something like PDE5 inhibitors, it's rigorous. You've got 4 phases in the FDA, many years, hundreds of patients, very rigorous process. A panel sits down to decide the risks and benefits. And so very, very rigorous. A permanent implant, let's say one of you wants to invent a permanent implant right now, it would automatically be classified as a class 2 significant risk at a minimum. You can't even do research on it without getting it through the FDA. Whereas in many of the things we're going to talk about, there's this cosmetic loophole. And basically what it is anytime you can demonstrate substantial equivalence to another product out there, you can do this bypass type area. Now that's tricky when you get into silicone because it's been grandfathered in, and hence you get this loophole. Now that's fine from a legal standpoint, so you can get something approved legally, but from a society and a scientific standpoint, what do we do with this data? And I would argue that this is kind of the vitamin or herbal equivalent for surgeons. You know, when you can get into this cosmetic loophole, it's something that it may work, it may not work, we don't know, but the testing hasn't been done in many of these therapies. So the SMSNA strongly supports innovation. It strongly supports advancement of sexual health, cosmesis, well-being. It also recognizes that the sexual health field is burdened by a huge abundance of illegitimate therapies out there, which include false claims, inadequate data, poor informed consent, and so on. The standard really is a high scientific threshold for this society. And we really do see ourselves as having a role in educating and warning patients about potential harms, both patients and clinicians. So as of 2024, the key issue here is lack of data. Most of the series are small, they're retrospective, single center, limited follow-up, a high percentage of missing patient data, which is a real key issue that we'll talk about. Minimal use of standardized assessments, and the AEs or the adverse events are likely significantly underreported. And that became a key determination for us. If we didn't feel we could adequately classify the complications, that by definition becomes an experimental therapy. So we're not trying to be derogatory with this concept of experimental, but just how do you counsel someone if you don't know the true risks of a therapy? So patient selection, the SMSNA felt that the standard here was a structured psychological assessment and counseling, particularly since the majority of these men fell within normal parameters as far as measurements. You also need to assess the ability of the patient to be able to cope with any sort of complication. And if we ended up classifying something as experimental, we felt this should only be done within the context of an IRB-approved study. So with that background in mind, we'll get into the statements here. So injection procedures, we'll start with the injectable soft tissue fillers. I just highlighted 2 of the therapies. There are more studies than this out there. Yang published 2 studies looking at hyaluronic acid versus polylactic acid filler. 24-week results show an increase in girth. You're roughly 2 centimeters. You lose about 10 or 20% by 6 months, and then you lose another 50% by 18 months of that girth. But very importantly, there weren't any real severe adverse events here. So you had some deformation, some inflammation. Most of these resolved by the time of follow-up, but nothing real severe or dangerous with these types of therapies. Now, in contrast, when you look at the permanent materials, that's very different. So there were severe complications here: necrosis, progressive pain, swelling, long-term deformities, staged procedures, grafts, things like that. So because of that, we differentiated the two. We said limited data suggests potential cosmetic benefits of temporary injectable hyaluronic acid and polylactic acid fillers to increase penile girth with an acceptable safety profile. Clinicians performing these are urged to conduct safety and efficacy analyses using IRB-approved research protocols. But the SMSNA strongly recommends against penile fillers using permanent materials, including paraffin and silicone. Okay, getting into surgical procedures. So suspensory ligament division, one relatively big study here by Rossi and colleagues, 245 men looking at primary lengthening. They did include a spacer here, a silicone spacer, showed increases in flaccid length, but here reported really no AEs. So 3% infection, 3% pain, but no urethral injury, no neurovascular bundle injury. A follow-up study, 61 men looking at a combination of the ligament release as well as paniculectomy, Z-plasty, did show 10% instability, 10% glandular numbness, higher penile edema rates. So really kind of mixed and limited data here, and it led to a statement saying the SMSNA identifies that in the hands of experienced surgeons, suspensory ligament division may result in increases in flaccid penile length, should only be considered after a comprehensive discussion of potential complications, which may include erectile dysfunction, sensory changes, penile instability, among others. So jumping into graft and flap procedures, there are multiple techniques described here, and they're all small series. These are often combined with other procedures, and you get girth increases, quite wide range there, from 1.5 to 5 centimeters, really minimal long-term data. But your adverse events here, again, are pretty high. So you've got hypertrophic scarring, penile edema, ulcerations, wound dehiscence, infections, and so on. Because of this, SMSNA recommends against the use of graft and flap surgical procedures for penile augmentation specifically until further outcome data are available. All right, now the big one that I think people were looking forward to here. So silicone sleeve implants. So ELIST had a study, 400 men. Importantly, 126 were not included in the follow-up analysis for it, showed increases in girth, 81% satisfaction overall. Now, the initial report had very low rates of AEs, so 5% seroma, 5% scarring, 3% infection, 3% removal, no impact on erectile function or ejaculation. A follow-up study, a different study, 49 men, showed 4 centimeter flaccid length changes, and again, AEs were relatively acceptable here, 2% infection, 4% erosion, 8% flaring, 6% revision. The problem is, since then, there's been some new data that's come out. Now, one little slide I just wanted to throw in here, because I think a lot of people don't know all of the details on IRBs and what's allowed or not. You are not allowed to publish or to analyze data if you have a financial vested interest in something. So just from a journal standpoint, from a ethics standpoint, you're not allowed to do like a prospective study on something. You can't be the one analyzing the data if it's something that you have a vested interest in. Now, that's different for retrospective type studies, but like in my specific case, I developed a therapy, and at Mayo Clinic, they said, look, you're not allowed to invest in the company. So you can either never invest in the company and you can do research, or you can invest in the company and then you can never do research on the topic. And so it changes quite a bit depending on your level of investment in something. Just a little side note. On the sleeve implants, so then some of these abstracts started popping up. Now, normally you don't accept abstracts in any sort of like formal publication. However, in the case of serious adverse events, you do accept them. And so things like FDA and other things will commonly allow these serious adverse events to be reported. So there was an abstract a little while ago, showed 11% device removal, 27% seroma, 6% revision. But then even more, we're starting to see these severe complications. So erosion, loss of sensation, de novo curvatures. One study showed 77% dorsal curvature, 62% length loss, 15% sensory changes, 15% ED, required implants, glandular anesthesia, anorgasmia. So again, if you look at that tolerance of AEs, there's some signals that were a little more concerning here. Because of that, the SMSNA recommends that silicone sleeve device surgery should only be performed under the oversight of an IRB with long-term safety endpoints and without cost to the patient. SMSNA additionally recommends against their use except in the hands of experienced surgeons and following a comprehensive discussion of potentially severe complications. Sliding and slicing techniques, real briefly here. So these are often done at the time of penile prostheses, and they increase the potential increased length at the time of the implant. Initially reported no higher risk of explantations. However, severe complications have also been shown here, including glandular necrosis. Most of the data is with malleable implants, and there's been numerous modifications reported as ongoing changes. That's usually a red flag anytime the technique is still constantly evolving. And that led to the SMSNA suggesting that penile slicing or sliding techniques are investigational, recommended they only be conducted with IRB oversight. SMSNA additionally recommends against their use except in the hands of experienced surgeons and following a comprehensive discussion of potentially severe complications. So just a couple future considerations. How could these statements change? If someone or a company wanted to come in and say, I want this statement changed, what's that going to take? Well, the key thing is well-done studies. So in the case of many of these, a multi-center prospective study evaluating complication rates, again, it can't be done by the investigators who invented the particular therapy. All-comer multiple attempts at outreach, directed AE questionnaires. So it can't just be I didn't hear from them and hence they never had complications. They have to be directed questionnaires for various symptoms. Tracked registries, where you actually, if I explant something from someone else, that still goes into the registry because the serial number is tracked. Generally for non-implants, that should be out to a year, and for implants, it should be out to 5 years and a minimum of 100 patients. And with that, I thank you for your time.